A very good day, everyone. And today's talk is about cardiac PV loop and cycle. And all my slides are available in www.painfreepartha.com website. And a few of the presentations are also available in YouTube channel Painfree Partha. So before starting anything on academics, I put a big salute to the Professor Ravi Shankar, Director C Dreams, and our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Not only these images, there are few other images which are coming in the slides or taken from the internet for closed academic purpose only. Now I put a cycle to know this is oriented towards cardiac cycle. So what is that? It is excitation of the myocardium. They develop a pressure gradient and a contraction, an opening of valves, ejection of blood. They started to relax. They develop again a pressure gradient, which is now down, opening of valves, flow of blood. Then go back again, excitation of myocardium, closure of valves, pressure gradient develops after contractions. Now, what is this PV loop? Pressure in y-axis and volume in x-axis. This is what is called a PV loop. And whenever we say PV loop, it is only about left ventricle. That is what we talk about when we say PV loop. There are four important phases. Ventricular filling, phase A, diastole. Isovolumetric contraction is phase B, which is systole. And ejection is phase C. It is also systole. And the ventricle starts to relax. It is phase T, diastole. Again, I will come back in different pictures. Now this is C, isovolumetric contraction and ejection. These two are systole. This is a pressure volume loop. And the isovolumetric relaxation starts and the filling starts. This is diastole. Now what is systole? What is B and C are systole, while A and D are diastole. Okay, A, B, C, D. D and A are diastole, while B and C are systole. The end diastolic pressure and end diastolic volume for the ventricle is there. That is what is EDV and EAP. As the ventricle begins to contract isovolumetrically, the volume does not change. The mitral valve closes and the left ventricular pressure increases. But the volume remains the same. That is what is called isovolumetric contractions, resulting in a vertical line because all valves are closed. Here you can see this is what is the isovolumetric contraction. Because filling is stopped, mitral valve is closed, the aortic valve is already closed. There are no valves open, so the volume remains the same. The left ventricle tries to contract with the same volume. The pressure increases, the volume does not change. This is isovolumetric contraction phase, phase B of systole. This is what happens. Both mitral valve and aortic valve are closed. The left ventricle starts to contract, tensed up, but there is no change in the volume. Now we go up. This is what is the isovolumetric contraction phase. As soon as the pressure goes up, the aortic valve opens and the ejection of blood starts. If the ejection of blood starts, the volume decreases. And this is rapid ejection and slow ejection. And this is what is C. That is also systole. So isovolumetric relaxation, contraction, rapid ejection, and slow ejection. These form basically the systole. Now, once the LVP, again, so I'm telling you, aortic valve opens and ejection phase starts. The volume decreases and then decreases as the ventricle begins to relax. Now you see this is aortic ejection phase. Now the volume decreases. Mitral valve is closed. If the mitral valve is problem, there will be mitral regurgitation. So here the aortic valve opens and this is what is called the ejection phase. Once this is what I am telling again, the LVP increases This is what is the ejection phase. Now when the aortic valve closes at point 3, this is what is point 3. Aortic valve closes. The mitral valve is already closed. So the ventricle relaxes isovolumetrically. The volume does not change, but the pressure comes down from 125 to 5 or 6. Understand? This is what is called the isovolumetric relaxation phase. This is phase 3 to 4. This is what is called D. This starts diastole. Now we are told B and C are systole, D is diastole. Now when the left ventricular pressure starts falling and falls below mitral valve or the left atrial pressure, the mitral valve opens and filling starts from LA to LV. Mitral LA to LV, mitral valve opens, filling starts. So the volume increases because this is not a problematic left ventricle. It's a normal left ventricle. So the filling does not increase the pressure much. That is what is the compliance. Very well, good compliant left ventricle. The pressure does not increase. See, the pressure is very mildly increased with such an increase of volume from 50 to 130, something like that. Here you can see 120, 130, and here it starts by 50. 70 ml increase, not much of increase. This is what is called the filling phase on rapid filling and slow filling. Rapid filling and slow filling, the last portion is the atrial systole. So these two forms, isovolumetric relaxation, rapid filling, slow filling, and atrial kick, these form the diastole. Now the stroke volume is end diastolic volume minus end systolic volume. So at the end of diastole, there is so much is there. Now the heart is pushing, there is such much is there. So 120 becomes 40. So 80 is out. That is the stroke volume. So what is ejection fraction? Stroke volume divided by total. So 80 divided by 120, that is what is 66%. That is what is we call as ejection fraction. I am very simple, and many of the facts which you may be knowing already, but still I am repeating for the basis of people who are not very good in physiology. Now again I am telling end systolic volume is 50 ml, end diastolic volume is 120, mitral valve closes and the left ventricular isovolumetric contraction phase starts, aortic valve opens, rapid ejection phase and slow ejection phase, the aortic valve closes, the ventricle starts to relax and isovolumetric relaxation, the mitral valve opens, LV starts to fill, there is not much of increase in pressure, but the volume rises. So this is B and C is systole, contraction and ejection, relaxation and filling is diastole. Again, I am refreshing passive filling from the right atrium, and this part is called the atrial contraction, atrial systole. So when we have, there are certain clinical, I am just touching some clinical things. Now this is what we know, this the normal PV loop of the left ventricle. Now we have sometimes the LVH. That is what I told. The time it starts to fill up, the pressure is high. Even this pressure is high, the baseline. So if for 10 ml increase in volume, the pressure should not increase by 1 or 2. It is increasing by 5 or 6. That is what is called less compliant. Delta P by delta V. The increase in pressure is high for the increase in volume. That is what is called the compliance of the LV. As soon as the LV gets hypertrophied, the end diastolic pressure volume relationships. So this is the curve. Here you can see the curve, and this is slightly going up with this point. So this is a sign of diastolic dysfunction because of left ventricular hypertrophy. I will be coming back again for these slides. Now, if you do an exercise, see here, all these things increases. The volume increases, the stroke volume increases, the ejection increases, everything increases. The curve is, see here, the compliance does not change. The curve pattern does not change. Isovolumetric relaxation phase is straight line like this. Isovolumetric contraction phase is light line like this. You can see the compliance is fine. You can see the ejection is fine. So in physiology, there may be increase in volume, there may be increase in cardiac output, but the curve structure does not change much. This is an increased inotropy and a decreased inotropy. Now we have got a preload problem. This is the normal curve. You can see the normal curve here. If there is a decreased preload, for example, diarrhea, for example, an ectopic pregnancy, excessive bleeding inside the pelvic cavity, there is no blood coming. So the volume filling up is low. And then you can see here that it cannot eject, no, it cannot eject more things and it is coming back again. But you see the curve structure is almost normal with a preload. When you see the increased preload, there is a lot of things. Yes, there is small increase in the pressure and the volume is increased and the pressure goes up, isovolumetric contraction, because the heart is normal. Preload is increased, preload is decreased. So that is what has happened. Here the preload is increased, here the preload is decreased. This curve, preload is decreased. This is ectopic. This we have given a lot of IV fluids. And see here, normal heart will function like this. But if you go to afterload, what is afterload? If you have an hypertension, if you have an aortic stenosis, the resistance to the left ventricular ejection is more. The LV is ejecting against more resistance. That is what I have told. It is hill up. If you are cycling in a mountain hill up, that is what is called the afterload. See, increase the afterload. The curve is like this. It is normal. Increased afterload. This is the normal curve. This is the decreased afterload. You can see the volume here coming down. This is at this pressure it starts to this. So this is increased afterload and this is decreased afterload. So there are so many terms. This is the stroke volume. This is the potential energy of the LV. This is the stroke work, end systolic pressure volume relationships, and diastolic pressure volume relationships, ejection fraction. There are so many terms. So why do we need this at all? PV loop, cardiac cycle, all these things. Now you take up mitral regurgitation. This is the normal loop. Now, as soon as this contracts, some portion goes into the aorta and some portion goes to the LA. Actually, the stroke volume may be high, but what is going into the aorta is maybe less. That is what I'm telling. Now, if the here into the aorta, if you decrease the resistance here, here more will be there, here more will be there, and LA will be less. So that is what happens when you give afterload reduction drugs in mitral regurgitation. If you give ramipril or enalapril, which decreases the afterload, here is the aorta. Aortic resistance is less. So this is pumping out and less resistance into the aorta, more blood will flow, and into the atrium, less blood will flow. So this is what is happens. The contraction, because there is a leak of the mitral valve. So you cannot get a proper isovolumetric contraction phase or sometimes even an isovolumetric relaxation phase. There is leaking going on. The valve is not intact. So it is not as straight as this. The curve goes like this slightly and pushes like this. Now you can see the width is increased in regurgitations. The width is increased in regurgitation. This is what we should know. The width is increased in regurgitant lesions. Now you see a mitral stenosis. Everything is pulled down like this. This is the normal black one. And here you can see because less volume is coming to mitral valve is stenosed. How much blood it will get? It will not get 120. It will get only 80, 90. So it has to contract and push up this everything. So here the mitral stenosis, not much of changes except there is a decreased volume here, end diastolic. That is what is. Preload is decreased, end diastolic volume. This leads to a decrease in stroke volume. There is no blood, decrease in stroke volume. Because the end diastolic volume is decreases more than end diastolic volume, the stroke volume also decreases. So the width is little less. That is what is the stroke volume is less. And the curve is slightly pushed, pushed to the left. So this is what happens in mitral stenosis. If you know the curve, yes, you can play with cardiac physiology. Now again, I'm telling aortic stenosis. Here, reduced ventricular stroke volume due to increased afterload. Aorta is stenosed. The left ventricle cannot contract. Afterload is high. So what happens is the end systolic volume is very high. After the contraction and ejection, it cannot do. Here, the volume is there. It has ejected 100 ml or 90 ml. It has ejected only 40-50 ml, and it is trying to do it at 70-60 ml at very high pressures because there is aortic stenosis. So there is an increase. So there is a compensatory increase in diastolic volume, and here again the isovolume. See, stenosed things. There is not much of change in the straight lines. See here, increased compensatory and this reduced ventricular stroke volume, increased afterload. The curve is like this, high. The width is not raised. The width is less, height. That is what happens in aortic stenosis. But here see aortic regurgitation. The height is not done. See the regurgitant lesions, the width is broad. It's broad. There is no true phase of isovolumic relaxation. See here, because there is a leak here, aortic regurgitation. Whereas increase the LV volume. Here also there is a leak. It tries here. LV pushes aorta and aorta comes back again. So that is what is the problem. There is no proper isovolumetric relaxation. There is no proper isovolumetric contraction because the aorta is leaking and the compliance goes, the volume goes like this here. LV begins to contract, blood is still entering the LV. So there is no true LV. So the LV volume is very high here. So this is what is the aortic regurgitation. Now if you want to see here, this is the normal. The blue one is the normal. The green one is the mitral stenosis. What is aortic stenosis? See here, height is raised. In mitral regurgitation, see here, it is shifted to the right and the width is high. In aortic regurgitation, this is what is the curve. So unless you are sure of how the curve behaves in each valvular lesions, we are not very clear about the treatment schedule. Now you can see these are all, if you have familiar things like this, we don't go for unfamiliar things. So we are not bothered about what is RV PV loop, right ventricular PV loop. See here, the end as in systole is 125, while the RV is here 25. It tries to contract here and ejects out and comes in like this. This is what is a approximate RV PV loop. Now this is what is being called as normal RV PV loop. See, when there is a chronic increase of afterload, for example, severe pulmonary hypertension, a chronic increase, the RV cannot contract. Pulmonary hypertension is there. The afterload of the RV is increased, so it will look like an LV. The PV loop is look like an LV in an RV. So if it is going to be decompensation may be due to different reason. It may be a contractile dysfunction, or it may be a regurgitant lesion. Whatever it is, the decompensation, the RV pressure volume loop is pushed here to the right. In dilated cardiomyopathy, the ventricle becomes dilated without compensatory thickening of the valve. So that is very important. It becomes dilated. The valve is not thickened. The LV is unable to pump enough blood. The end systolic and end diastolic, both volumes increase. The end systolic volume is increased, end diastolic volume is increased, and the end systolic volume is increased. And the contractility is also decreased. So more blood is staying here. Now we know what is we concentrate here. This is normal, but there is a diastolic dysfunction. The relaxation is not proper. It is not complete. So what happens is, here you can see the pressure is doing like this. It is not like this. Now you can see fire, diastolic heart failure. You can see this is what is the diastolic heart failure. The contraction is good, the ejection is good, the relaxation is also okay, but isovolumetric. But here the compliance is bad. The volume increases, the pressure increases very much. So this causes a diastolic failure because of some other cause. Diastolic, it may be a severe LVH, whatever it is, diastolic heart failure. But we go here, this is diastolic heart failure. The contractility is poor. Systolic heart failure, it cannot contract. Now here, you can see here, the curve is similar. The compliance is not much, but it cannot push out. The volume is high, end systolic, the end diastolic volume is high. It contracts, but it cannot eject. It contracts, okay, but it is not powerfully ejecting here. And again, the end systolic volume and the end diastolic volume are high. The curve is shifted to the right. This is what is systolic failure, and this is what is diastolic failure. Any other thing about this PV loop? Yes, conductance, because the heart is filled with so much of blood. So the electrical conductance, blood without blood, may vary. This is what is being used in many of the cardiac output monitors and many other things. It is just a cardiac cycle. That is what we should know. It is systole and diastole. What happens is systole, isovolumetric contraction, ejection. Then comes back isovolumetric relaxation and rapid filling, slow filling, and atrial systole. It's a cardiac cycle. That's all. And thank you very much for the patient listening. Thank you very much. And subscribe to my YouTube channel, Painfree Partha, for more videos. And thank you, doctor. And thank you all for the patient listening.